health. And our next speaker has both medical and law degrees. That wasn't enough. He then went on to establishing one of the Midwest's first electronic health recorded enabled primary care practices in the US, followed by numerous leadership roles. Please welcome on stage Dr. Kaveh Safavi, Senior Managing Director of Head of Global Health Practice, Accenture Health. Hi. Lovely to see you.
Good morning. Thank you for having me. I'm going to take a few minutes to maybe expand this conversation a little bit. The popular narrative around the benefit of artificial intelligence in healthcare has largely been focused on making better decisions, smarter decisions for doctors, helping patients navigate their own healthcare, and in the triangle of access, affordability, and effectiveness, the three big challenges that healthcare struggles with, that's all on the effectiveness side. I'm going to suggest and show you some data that might say that the real transformative opportunity for artificial intelligence is actually on the affordability side of the equation, and maybe on the access side of the equation, as opposed to just the effectiveness side of the equation. In fact, I'll share some data about what healthcare leaders are thinking about the real power of artificial intelligence. And hopefully you'll begin to see that this is really a tremendous opportunity. We're only beginning to scratch the surface of it. The reason that I want to talk about affordability is because if you think about the way that our common narrative around healthcare, it's basically this idea that if we could just make healthcare a little bit smarter by finding who the sick people are, if we could figure out how to get the practice pattern variations out of the healthcare system, get the handoffs a little bit better, get the patients to follow doctor's orders, and maybe also to get the patients to live a healthier lifestyle, that's going to crack the code. And particularly for public healthcare systems, where the only source of money is really taxation. And if healthcare costs grow at a rate that isn't supported, then some other services have to be cut off, then it really becomes a pretty big challenge. And a lot of the work that we talk about now in terms of better medicines are fantastic, but there's a real concern that that might make the cost go up, not down. We talk about this idea that access always drives affordability, makes it harder, not easier. I'm going to make an argument that there's actually a different metaphor. And here's the evidence. First, if you actually look at what's going on with healthcare costs globally, you see a very interesting phenomenon. This is OECD data. This is for 10 years. It basically shows you that in every country, no matter how healthcare is paid for, public or private, no matter what the rate of expenditures are, those countries experience a cost increase that's equal to their GDP plus 1 to 3%. That's the same in the United States, by the way, that spends twice as much as the OECD average, but is in this number. That's the same in Canada, that's the same in Norway, that's the same in Australia. These are all countries that I've looked at and worked in. They all see the same thing. In fact, the US data goes the same back to 1960, and the 2026 projection is healthcare will grow 1.5% faster than GDP. Why is it that it grows at that rate? Well, one of the really interesting observations is that as a sector, healthcare has actually been losing productivity as opposed to gaining productivity compared to all other sectors. And that basically means that it requires more people in order to produce a unit of care compared to all these other sectors, which have largely figured out how to move work either to machines or to their customers. The reason that this is important is because healthcare is viewed as one of the few labor-based economies. In fact, it's about 65% of all costs come from humans, from people. And in every country, wages will never grow at a rate smaller than the overall GDP. And then when you include scientific innovation that allows us to convert non-disease to disease, and an aging population that brings with it a disease burden, there is no conceivable way to change the relationship between healthcare costs and the overall economic expansion in a country without figuring out a way to provide healthcare without requiring people to do the work. That is the only lever that we can pull to change those two relationships. So the idea of shifting work either to the patients themselves or to smart machines is critical. We've had no answer to really solve that problem until recently. And the advent of artificial intelligence has really provided us with the first real opportunity to think about how we're going to shift this work from the caregivers, the model that we have today, to somebody else. Now, I want you to take that concept and I want you to superimpose it on a second concept, which is the issue of access and the perspective that patients have about the healthcare system. The World Health Organization has estimated that by 2030, there will be a 15 million person healthcare worker shortage. There is no scenario where we can close that gap simply by creating more healthcare workers. It's impossible. We cannot educate or mint them. And even if we could, we couldn't get them to the places they're needed. If you think about where technology doesn't exist, where broadband doesn't exist, oftentimes we have to have lay healthcare workers physically in those areas, often offline doing the work that they need to do. So the idea that we're going to solve this access problem by creating more of a traditional system of interaction between a patient and a caregiver is completely impossible. That's one problem. That's an access problem. The second problem is what people expect from their healthcare system. In all industrialized nations where we've been looking at people's own sentiment about their healthcare system, we see an increasing gap between how people think healthcare should be and how it is. And that's because their perceptions and their experiences from outside of healthcare continue to show them that this model simply isn't going to work. What they look for are things that you see here. This comes directly from experience design work done with people trying to navigate the healthcare system, where they are describing, where you're observing them, and this is what they're struggling with. Now, what you don't see on here is technical or clinical decision making. That's not to say that's not important, but as you ask people who struggle through the healthcare system what they really need, these are the kinds of things that they talk about. So when they make the judgment about whether or not the healthcare system is working for them, whether they're getting their money's worth as a taxpayer or a private payer, these are the kinds of things that register. And what we know is that the direction of travel of the healthcare delivery system is going from one that is largely about an interaction with a physician in person or a clinician in person, face to face, to one that has several elements. It's self-service, it's much more blend of physical and virtual, and it's fundamentally location agnostic. These are the three elements that the healthcare system will continue to become more like. All of these become enabled by technology, but specifically by artificial intelligence, because it's impossible to get to a level of self-service without including intelligence in it, as you heard the Babylon example, for example. But I want to talk about the data around affordability and productivity specifically. We've done some work, for example, looking at the experience, the workload of in the United States we call it a primary care physician, think of it as a general practitioner equivalent. What we've discovered is that about 18% of the work that is done in that interaction with that clinician is what we describe as information gathering work. Around 11% is what we would call simple advice. So almost 30% of the work that's being done in that interaction could probably be done by a smart machine or the patient themselves or another clinician or maybe a layperson with some technology. All of that creates capacity in the healthcare system. You heard the Babylon example for simple triage. In the UK, there is a company that is focused on behavioral health, Silver Cloud, that's built in cognitive behavioral therapy, now bringing artificial intelligence in. They've demonstrated that therapists can take care of 6 times as many patients when they augment their practice with this technology as opposed to by themselves. And then finally, one of the greatest sources of lost productivity currently, particularly in countries that have electronic health records, is the introduction or the typing or the putting of data into healthcare systems. In the United States, it's estimated that physicians have lost 10 to 15% of their productivity just for the purposes of documentation. And now as we're beginning to see artificial intelligence meet traditional voice and speech recognition in our consumer world, there are several startups that are focusing on putting passive listening type technology in an exam room to allow us to begin the process of structured documentation, workflow evocation, and eventually giving some of the time back to the doctors to either see more patients or to spend more time with the patients they're seeing. If you're following this area in the United States, there's a company called Suki and there's a company called Forward Health, both of which are just beginning to put their technology in and try to validate the results. I think you're going to see more of this as well. But this is designed to show you that there is a tremendous amount of real productivity that can come from these kind of smart technologies. So we then set out to really find out what people are thinking. We did a 6-country study. These are European plus Australia, and these are payers and providers, and these are leaders. And the first thing we asked them was, relatively speaking, how important is artificial intelligence as a priority in your organizations right now? And what you see is interesting. First of all, you see the AI component of technology getting close to 50% in a couple of countries. I think it's interesting to see how Spain and Singapore are actually leading the way with AI. And Norway, and particularly Australia, have less of a view of the role of AI. Not all technology, but specifically AI. I think when I spend time in these countries, this is very consistent with the experiences that I've seen, which is the robustness of the country's theory around using technology to substitute for labor, either because it's driven by access or by other ideas that self-service is a good thing, tend to be what elevates some of those results. The US was not done in this study, but if you put it on, you'd see it around between 45 and 50% in other work that we've done. But this tells you, number one, that artificial intelligence matters, but not equally in all countries. And it's very much reflective of the culture of that country, because obviously the technology itself could have the same uses in every country, but the different countries have different theories on it. In many of these countries, they're primarily thinking about artificial intelligence largely as a tool for either diagnostic decisions for doctors or drug discovery and other kinds of things, things that we've talked about or will talk about most of today. What I find particularly interesting, and this is the last piece of data that I want to share you, is when you ask people what their perceived benefit is of artificial intelligence. I actually pulled out 2 results. I pulled out the dark bars, which represent the answer to the question being it's transformative. And the lighter bars represent the question it's substantial. And if you look at the cumulative responses of the healthcare leaders, these are payers and providers in those 6 countries, what you see, first of all, is that the things that are at the top of the bar represent basically things that drive that drive cost reduction and affordability, largely through productivity. If you look, better clinical outcomes in total is second from the bottom on this pile and this list. But more importantly, look at what is the answer to the question transformative. And I'm going to ask you you could look at cyber as its own, or you can think about cyber as an operating cost. But if you look at the dark blue bars, the largest dark blue bars outside of cyber are operational efficiency. Then you see cost savings, improve analytic capability. Actually, if you look at better clinical outcomes, it's relatively modest in the transformative. It's pretty large in the substantial. I think what this tells us is that there is a recognition of what we can do with AI today and what we can do with it tomorrow. And also a recognition that the healthcare system, the way that it's currently organized, which is largely requiring us to have an interaction face-to-face with a caregiver, has some fundamental limits that essentially constrain overall affordability for every country. And we need to create and liberate the capacity from the way we operate our healthcare system in order to invest in better clinical decision making, in order to be able to invest in allowing patients to have access to the drugs that are going to be discovered. Because in the absence of that, what we're going to have is a scenario where we are able to create the ability to treat more conditions, but have to artificially constrain our ability to treat those conditions. Because the total cost of care is going to continue to march forward because it's a human labor-based care model. And the wages of the people in the healthcare system are going to grow at the same rate as the country's ability to generate taxes to pay for their healthcare system, leaving it with no real good alternative. So that access, affordability, and effectiveness triangle historically has been viewed as an iron triangle. If you try to make access greater, you make affordability worse. If you try to make effectiveness greater, you make affordability worse. What I would argue and suggest to you is that artificial intelligence has given us the first real opportunity to break that triangle and allow all 3 of those dimensions to improve simultaneously, something we've never really had the luxury of having. And that the care system that we're going to experience a decade or 2 decades from now will look different than the care system that we have today, not just because of the science, but because of our ability to provide care without requiring us to have a physical interaction with a caregiver as the primary mode of receiving that care. With that, thank you very much for your attention, and I look forward to joining you for the rest of the day. Levita?
Thank you so much. Global trends there. I'm just going to open up to the floor. Any questions here, please raise your hands. Just over here, we'll bring a microphone to you, and if you can just let us know your name and where you're from. Thank you.
My name is Rex Clemens, and I'm from Sandoz. So I have a question for you related to the change in the care system and the increase in productivity. When you look at disease states, especially acute diseases that rely on visual diagnosis, scarlet fever, to some degree strep throat, skin lesions, and we already see the advent of AI systems in that. Do you see a world in the next 5 to 10 years where for any acute diagnosis, the primary care physician, dermatologists, radiologists become disintermediated, and there's a possibility in advanced economies and maybe even developing economies to move that entire cycle between the patient and the provision of the drug, and have no physician in between, but have that completely done electronically? And if not, what are the barriers to that happening other than just pure regulatory barriers?
Yeah, I think it's a great question. Unlikely in total, because one of the challenges is that if you just think about the question, can a patient's diagnosis be made strictly by taking biological data? Purely and simply. The problem is that it completely lacks context, historical context. If you measure somebody's biological data, you have no idea what that has been over some period of time. It's typically the history that avails us of that. So the likelihood of the ability for a person to make a diagnosis without any information about context from that patient is unlikely. The ability to elicit that information raises an interesting question, because then you might ask the second order question is, why can't I have a machine elicit that history? I would argue that the ability to train an artificial intelligent agent to replicate a physician would require us to fundamentally reproduce the sum total of learning experiences of a physician and put it into an artificial intelligence agent in order to get them to ask the questions that they need to ask correctly. So I see this very much the way others have. And Fry and Osborne in 2013, when they did the list of professions that are likely to be disintermediated by artificial intelligence, put healthcare at less than a 1% probability of complete disintermediation. Largely because I think what happens is a set of tasks get removed and improved, but the totality of what you need in terms of clinical judgment, there's a large residual of that that's still going to be human. So it'll be both, but it won't be just complete disintermediation.
Is that something that you wanted to see more of? I don't know if we've still got the microphone to you, but possibly.
More disintermediation. I think to me it's more a case, an example is I'm a parent of a young boy, and if a kid gets diagnosed with something in kindergarten like scarlet fever for a 2-year-old, by the time that diagnosis is done by a physician, due to the access and the time to see, that infection is spread. So what I see is that in acute, very confined scenarios, having capability to do a highly rapid diagnosis, and I take your point on history, but I think in many of the acute situations, perhaps there's not so much need for the history, and you can much better improve outcomes.
Okay, thank you.
It's a continuum.
There's a gentleman just here at the front. There we go. Question to you. Thank you.
My name's Sanjay Wijay-Telekar. I'm a consultant in intensive care medicine. Thank you for an absolutely fascinating talk. Question regarding the slide which showed the efficiency of healthcare. Do you think there's any aspect there to do with patient safety from the point of view of the reduction in working hours, particularly of residents? My generation worked 90 hours. Our current generation, following the European Working Directive, works about 48 hours. And the generation below me has got a different approach to work. They want to work part-time. They want to do other things. So that I think, in fact, it'll get even less efficient. Do you have any thoughts on that?
Thank you.
I grew up in a generation where I didn't have a day off when I trained for 50 weeks, not a single day off. So I understand exactly what you're talking about. I think the answer to that question is that's almost a separate issue. The issue of whether or not you can whether you can use humans and machines to solve the problem just defines the total requirement for human beings. And then within that, the nature of work and people's expectations of how they're going to work fits inside of that. I think one of the things that you're going to see is that we don't actually know what it's going to be like to practice as a doctor in an environment where the machines take all the easy tasks away, because that creates a problem called cognitive overload. And what we've already demonstrated is that a physician cannot work at full productivity in a continuous manner the way they do today. So I don't even know what work really fully looks like in this combined world. So my ability to even answer the question, what is a lifestyle like, is basically impossible, except to say that it will not even look like it looks like today, and then we'll go from there.
Thank you very much. We'll have to leave it there, but I love that term cognitive overload. I think that's what my GP had when he had to Google something that I asked him the other day. But for now, thank you so much for that. Really interesting, and I know that you'll be around if people want to grab you and have a chat.
Good. Thank you.
Thank you so much. Dr. Kaveh Safavi there.